This is the selection criteria for surgery. Right now, my selection criteria is strict by the book. We are a new program, so I'm not going to try to be a hero here. So the age cutoff is 65, but I think we need to change that, because as more and more people live older, and there are a lot of healthier 70-year-old people, we need to make it more. We need to make it available for them. The surgeries can be broadly classified into restrictive or combined. Restrictive is bypass, band, sleeve. Sleeve and band. As the word suggests, the concept is you restrict the amount of food that the stomach can handle. And combined is restrictive with malabsorption. So gastric bypass, BPD, duodenal switches fall into this category. I think that the three surgeries that are currently the standard and have stood the test of time is bypass, band, and sleeve. BPD is a great operation, but with a lot of malabsorption complications. So the right patient for BPD or duodenal switch has to be somebody who is obsessive compulsive about the vitamins. And I think we all know that if you're practicing in St. Michael's, in Newark, we are not going to find a person who is going to be that regular about taking vitamins. So I don't want to do a procedure that can cause harm, which is why I'm sticking to bypass, band, and sleeve right now. I can like go into details about the surgical procedures. That's obviously my favorite part of the talk, or I can just go over it because I don't know how many people actually want to hear about surgery. So you guys can let me know if you want me to go into the detail or not. I have videos about how these procedures are done in a cartoon fashion, so not in a real life. And I can just go over the salient features between bypass, band, and sleeves. Okay, nobody wants to say anything. Okay, okay, Dr. Miller, okay. Before I go into the individual things, there are a few things I want to clarify. The band, in simple words, the band was made very popular because of a lot of marketing by Allergan, which is one of the companies that make the bands. So you'll typically have a patient come in saying, I want the lap band. Lap band is a trade name for that company that tells you marketing works. And I hope our administration is listening to that. Marketing works. Okay. So the problem with the band, so the band is the easiest, simplest procedure to do up front, has the lowest complication rate up front. But the band stays in the patient for life. It can be removed, but again, I don't like to have a patient with this mentality that, oh, I'm going to do this temporary and then I can remove it. So I tell them, if you come with that mindset, I'm not going to be operating on you. You have to come in with like, I changed my life from today for the rest of my life. So a foreign body is sitting in that patient for years. Now the average age for a bariatric surgery patient is pretty low. It's in the 30s. So they're going to spend 30, 40 years of their life with this foreign body. It's going to create some problems. Slippage, migration, erosion. And when it comes back with that problem, they can be really bad because it happens years later. They have stopped seeing their surgeon, so I require that everybody has to come once a year. I make them sign a contract separate from the surgical consent. Let's see if they actually stick by it, but the contract says regular follow-up. And so if they don't come for follow-up, there's no way of knowing that the band is slipping, migrating, or eroding unless you get a phone call from the ER, and it's a little too late by that time. Now, the band is a good operation for the right patient, and the right patient is somebody who does not have a lot of excess BMI. In other words, BMI in the 40s and above, I would be hesitant to give a band because you have to lose a lot of weight when you fall in the high BMI category. So what I mean by a lot of weight, the way we measure weight loss with surgical procedures is by the term percentage excess weight loss. So if a patient's idle body weight is 150 and they're 250, they're 100 pounds above the idle body weight. So that's 100 pounds excess weight. We gauge the three procedures, I'm talking about the band, bypass, and sleeve, in terms of what is the percentage excess weight loss that these procedures will give me. Average percentage excess weight loss with the band is in the 30s, with the bypass is in the high 70s, and the sleeve is the high 60s, early 70s. So you can see right off the bat that by the nature of that operation with the band, they're not going to be able to lose a lot of weight. Now, if they are in the BMI of the 30s and they're not diabetic and they just have some high blood pressure, borderline, yes, and they're motivated. So motivated, exercise, committed for follow-up, that's the patient to put the band in. For all others, I don't think you're doing them a service. Now, another question comes up, am I going to get too thin? The percentage excess weight loss, if the bypass, which is the gold standard, you can say, gives you higher 70, you are never even close to the ideal body weight. That has to be 100% excess weight loss. So people who have become malnourished is a complication of that procedure, not the outcome, not the normal expected outcome of that operation. And that, of course, is if you have more malabsorptions, any complications, whether it's technical or vitamin deficiency or whatever, can be the reason for them being malnourished. But these procedures are not supposed to make the patient even as close to ideal body weight as 80%, not 100%. Now, I've seen band patients drive their percentage excess weight loss all the way to the high 90s. The committed patient who is obsessive compulsive about their weight, they will do great because it's really literally is a tool. There's so much fluid I can put in the band because if you put too much, that is where the slippage and the erosion and migration starts. I've had a patient who I inherited from another practice who's very upset with me because I took the fluid out. It was too tight. And I'm like, look, you're fine right now, but in 6 months to a year, you're going to have a problem. So I took it out and she was really upset at me. And and I told her, I have to do what I think is the right thing for you. I can't make it too tight so that you just continuously vomit. That's how they get into that cycle. They vomit and they know that every time they vomit, they're going to continue to lose weight. So it's a whole different set of problems that you have to deal with when you throw in a band. The sleeve gastrectomy is an old and a new procedure. It's an old procedure because it was the first step in the two-step duodenal switch procedure. So back in the open days, a sleeve gastrectomy was done open. The patient would be sent home, that's stage 1, brought back again when they had lost some weight, and then the duodenal switch part, which is the malabsorption part, would be done. Because it's a high-risk procedure, the lower the BMI, the more safe it is. And one surgeon said, you know what, they're losing so much weight even before the duodenal switch, let me see what happens if I don't do the second stage. And that is how the sleeve gastrectomy came about as a standalone bariatric procedure. And we have around 7 to 8 year outcome data, so that's how long it has been around. Excellent short-term, excellent mid-term results. Obviously, we're now waiting to see greater than 10-year results. When I mean by excellent results, the percentage excess weight loss in the high 60s, very close to the bypass, resolution of diabetes. So it's a metabolic operation. I look at the band as a bariatric operation. Their diabetes or high blood pressure is going to get better as a factor of losing weight. With bypass and sleeve, their diabetes gets better before weight loss steps in. It's a metabolic operation. I think this, it's still here. So in other words, we operate on a patient, we do a gastric bypass or a sleeve, and I've recently just had more experience with the sleeves. We send them home without their diabetic medications, which means no insulin, no oral hypoglycemics. It's very powerful to see that change in your patient. I'm going to just show the videos of how these 3 procedures are done, and then we can go into the details if you like.